Keeping up with the latest research in myasthenia gravis can be a challenge, but it's so important for us neurologists.
It really is.
And today we're doing a deep dive into a study on IVIg maintenance therapy.
Oh, good.
It was published in Muscle and Nerve in 2025.
Looking forward to this.
The title's a mouthful: Efficacy and Safety of Maintenance Intravenous Immunoglobulin in Generalized Myasthenia Gravis, Patients with Acetylcholine Receptor Antibodies. A multi-center, double-blind, placebo-controlled trial.
I remember that one.
By the end of this deep dive, you'll have a clear understanding of this trial and how it might change how you treat your MG patients.
You know, IVIg is often used for acute exacerbations of MG,
Right.
but its role in long-term management hasn't been as clearly defined.
Yeah, and that's exactly what this study was trying to figure out.
Interesting.
It was a phase 2 multi-center international randomized double-blind placebo-controlled trial with 62 patients with generalized MG. All of the patients had to test positive for anti-acetylcholine receptor antibodies and have a quantitative MG score or QMG score of at least 10.
So they were looking at patients with a certain level of disease severity.
Exactly.
Yeah.
And all the participants were also getting standard care for their MG.
What did that involve?
Oh, it could be a few different things. Some were on cholinesterase inhibitors, only some on corticosteroids, and others on non-corticosteroid immunosuppressants.
So a mix of treatments.
Yeah, pretty diverse group. And then they were randomized into two groups.
Makes sense.
The first group got the IVIg treatment, a loading dose of 2 grams per kilogram over 2 days, followed by 1 gram per kilogram every 3 weeks for 21 weeks.
And the control group?
Placebo on the same schedule.
Got it.
The main thing they were looking at was the change in QMG score at week 24 compared to baseline.
Trying to see if IVIg was more effective at improving muscle strength and function.
Right.
Did it work?
Well, the results weren't as clear as we might have hoped. There wasn't a statistically significant difference in the change in QMG score between the IVIg group and the placebo group.
So no big advantage for IVIg on that main measure of muscle strength.
Not on that measure, no.
But I know they also looked at other things, secondary endpoints.
Yes, they did. And that's where things start to get a little more interesting.
Okay, tell me more.
One of the secondary endpoints was the percentage of patients who showed at least a 2-point improvement in their MG activities of daily living score, or MG-ADL.
Okay, how did that look?
70% of the patients in the IVIg group showed that level of improvement compared to just 40.6% in the placebo group.
So even though it didn't significantly improve muscle strength overall, IVIg seemed to have a positive effect on daily activities.
And this difference was statistically significant.
Interesting.
That's a key finding. You know, for us neurologists, it suggests that IVIg may actually have a real impact on patients' quality of life, even if it doesn't drastically change their muscle strength scores.
I see what you mean. There were also some other differences favoring IVIg in various exploratory endpoints, like the MG Quality of Life 15 score.
Yeah, several things worth looking at.
It sounds like we've got a lot to talk about.
Definitely. So much to think about with this study.
There is, too. The design itself was really interesting.
Yeah, very targeted.
Tell me about the patient criteria again.
So they had to have generalized MG and positive acetylcholine receptor antibodies.
Right.
But they also had to have a QMG score of at least 10 at screening.
To make sure they were having noticeable symptoms.
Exactly. These were patients who were likely needing more than just cholinesterase inhibitors to manage their MG.
And their treatment regimens could vary.
Oh, yeah. Some were on cholinesterase inhibitors only, some on corticosteroids only, and others on non-corticosteroid immunosuppressants.
That makes it more like what we see in our practices.
Real-world scenarios for sure.
Speaking of real world, what about missing data? Did the study count for that?
They did. They used a last observation carried forward technique for the analysis.
So if a patient dropped out before week 24?
Their last QMG score was used.
Interesting. Did a lot of patients drop out?
Not really. The dropout rates were pretty balanced between the IVIg group and the placebo group.
What were the numbers?
2 patients in the IVIg group withdrew because of exacerbations,
Okay,
and 8 patients in the placebo group discontinued.
I see. And were those dropouts all for the same reason?
6 of them withdrew their consent, and 2 had exacerbations.
So it seems like the dropouts didn't really skew the results one way or another.
Right, and then they did some subgroup analyses too.
To see if IVIg worked differently depending on other medications.
Exactly. They found that for patients on non-corticosteroid immunosuppressants,
Yeah.
there was a bigger change in QMG score from baseline in the IVIg group compared to the placebo group.
but not for the other subgroups.
Right. The other two subgroups, those on polynesterase inhibitors only and those on corticosteroids, only didn't have enough patients to really draw any conclusions.
Makes sense. So potentially a synergy between IVIg and non-corticosteroid immunosuppressants.
Something to look into for sure.
Definitely. Let's go back to safety for a minute. Are there any other things that stood out to you from the study?
Hemolysis was one thing that caught my eye.
Okay.
10 patients in the IVIg group met the criteria for potential hemolysis.
But was it actually a problem?
That's the interesting part. 7 of those patients weren't anemic. Their hemoglobin levels were still normal.
So maybe hemolysis isn't as big of a risk as we thought.
It's possible, but we need more studies to know for sure.
And what about other blood values?
Well, shifts from normal to low values for hemoglobin hematocrit and erythrocyte count were more frequent in the IVIg group compared to the placebo group.
But those effects were usually transient.
Yeah, usually.
Sounds like something to monitor, but not necessarily a reason to stop treatment.
I agree. It's all about balancing the benefits with the risks. And of course, we can't forget about those exacerbations.
Right? 3 out of the 4 MG exacerbations that required hospitalization happened in the IVIg group.
So it's important to carefully consider the potential benefits of IVIg maintenance therapy against its risks.
Absolutely. So much good information to think about.
This study was so well designed.
Yeah.
And the data is so valuable for us neurologists.
I'm sure. It really helps us understand these findings and what they mean for our patients.
It's not just about the top-line results.
It's about understanding all the details.
And using them to make the best decisions for our patients.
I'm really looking forward to hearing your expert analysis of what all of this means for us in part 3.
Sounds good.
So we've really dug into this study.
We have.
Looked at the design, the data, the safety considerations. Now, how do we actually use this information to help our patients?
That's the big question, isn't it?
It is. This study doesn't give us a definitive yes or no answer about IVIg maintenance therapy for all MG patients.
Right. It's more nuanced than that.
So how should we be thinking about it now?
I think of it as another tool we have.
Okay.
But we need to be smart about how we use it.
What do you mean?
Well, it's reasonable to think about IVIg maintenance therapy for patients who aren't doing well enough on other treatments.
You mean if their symptoms aren't controlled?
Exactly. Or if they're having bad side effects from those other treatments.
I see.
And remember, the primary endpoint, the change in QMG score, wasn't statistically significant.
Right. That makes me a little hesitant to use IVIg maintenance therapy, honestly.
I understand that, but we have to look at the whole picture.
What?
The MG-ADL scores.
Oh, right. IVIg did improve those.
And significantly.
So even though it didn't really improve muscle strength overall, it could still help patients in their daily lives.
Exactly. And we can't forget about those other numerical differences favoring IVIg.
You mean the quality of life scores?
Those and the percentage of patients who were classified as improved on the MGFA post-interventional change status.
Sounds promising.
It does.
Yeah.
But we always have to think about the risks, too.
Of course. We talked about hemolysis.
And those exacerbations in the IVIg group?
So monitoring is key.
It really is. We have to be on the lookout for any signs of adverse events.
And adjust treatment if we need to.
Absolutely. You know, at the end of the day, the decision to use IVIg maintenance therapy is a personal one.
Between the doctor and the patient.
Exactly. You have to consider each patient's individual needs and preferences.
And really talk through the potential benefits and risks.
Openly and honestly.
This study gives us some good data.
A lot to think about.
But we have to remember that it focused on a specific group of MG patients.
And we need to be careful about applying the findings to everyone.
Good point. So what are the main takeaways for neurologists?
I'd say approach IVIg maintenance therapy with cautious optimism.
Okay.
It could be really helpful for some MG patients.
But it's not a magic bullet.
Exactly. Evaluate each patient carefully.
Think about their individual needs and preferences.
Have those conversations about the benefits and the risks.
This has been a really great deep dive into IVIg maintenance therapy. We've covered so much.
Hopefully it's helpful for our listeners.
For all of you neurologists out there, keep learning, keep exploring, and we'll see you next time for another deep dive.